The following podcast is part of a certified educational activity titled How I Think, How I Treat: Contemporary Insights on Diagnosing and Managing SSc-ILD in an Evolving Treatment Landscape, with Drs. Lisa H. Lancaster, Fernando Martinez, and Elizabeth Volkman. Access the entire activity and complete the post-test at peerview.com/RUB860. Downloadable slides and practice aids are also available.
Hi, everyone. I am Dr. Lisa Lancaster. I direct the Interstitial Lung Disease Program at Vanderbilt University Medical Center, and I'd like to welcome you today. We're looking forward to discussing insights on diagnosing and managing systemic sclerosis interstitial lung disease. And today I'm lucky to have with me Dr. Fernando Martinez and Dr. Elizabeth Volkman. So let's go over the agenda for today. We're going to start by looking at systemic sclerosis, the signs, the symptoms, and how to accurately put together a diagnosis. We're going to follow that with understanding disease progression and trying to make a diagnosis as early as possible when interstitial lung disease can appear. Then we're going to follow that with a discussion of immunosuppressions and the role of antifibrotic therapy in systemic sclerosis interstitial lung disease. I'd like to introduce Dr. Elizabeth Volkman now, who's Assistant Professor of Medicine in the Division of Rheumatology at UCLA School of Medicine. Dr. Volkman, thank you so much.
Thank you, Dr. Lancaster. It's a pleasure to be here today. And I'm happy to introduce to you the topic of interstitial lung diseases. So interstitial lung diseases, or ILD, refers to basically a heterogeneous collection of over 100 distinct lung disorders. And typically the presentation of ILD can be very nonspecific, especially early on in the disease course. So patients can present with dyspnea on exertion. They can have a chronic cough. And in some cases, they just may have fatigue on exertion. In addition, typically patients have diffuse bilateral infiltrates on their chest imaging. And when they have pulmonary function testing, they demonstrate restrictive physiology. So this is characterized by a decrease in the FVC, a decrease in the DLCO, and a normal FEV1 to FVC ratio. When we look at the estimated relative distribution of specific ILDs in the United States, you can see that they all have a relatively different proportion. So if we look at something such as IPF, or idiopathic pulmonary fibrosis, this comprises about 20% of ILDs. When we look at connective tissue disease-related ILD, this is also about 20% of ILDs. And given the myriad of causes of ILDs, it can be very helpful to have the multidisciplinary discussion group. So this is basically an approach that helps take into account consideration from rheumatologists, pulmonologists, thoracic radiologists, as well as pathologists, and sometimes even respiratory therapists. And typically these are conducted in person or virtually, where each of these integral parts of the MDD weigh in on a particular case to help develop a diagnosis based on consensus and also to help develop the treatment plan. So there are a number of benefits of an MDD, and this has been demonstrated in different studies. So one of the benefits is that it can increase your diagnostic confidence by refining a provisional diagnosis. In addition, studies have found that it enhances the inter-observer agreement on a diagnosis, and ultimately, this helps increase the diagnostic precision. So when we have a patient with ILD and we're considering, does this patient have a connective tissue disease, it's very helpful to go through an algorithm. And this usually starts with a very comprehensive and detailed history and physical examination. In addition, patients should undergo lung function testing, have a 6-minute walk test, an echocardiogram, as well as a high-resolution chest CT without contrast. And they also may, in some cases, undergo a lung biopsy. It's very helpful also when you're considering if a patient has a connective tissue disease to consider autoantibody testing. This can be helpful in terms of determining the phenotype of the ILD and may also give some prognostic information, which we'll talk about later in the talk. Then once all of this data has been collected, it's very helpful to then have the MDD discussion. And at this time, the diagnosis can be made based on consensus. So you can see here that there's a number of different causes, with CTD-ILD being one of them. And within that category, patients can have diseases such as rheumatoid arthritis, myositis, lupus, as well as systemic sclerosis. So as we go to the next slide, we're going to talk about systemic sclerosis. And this is a relatively rare autoimmune disease. So the estimates in the US range from 14 to 44 per 100,000 in the population. This is a condition that's much more prevalent in females compared to males, as well as in African Americans. And when we determine whether ILD is present, the prevalence can vary in scleroderma, and lots of times this relates to how the studies were done. So whether or not a study used HRCT to screen for the presence of ILD, or whether a study used pulmonary function testing, can influence what they describe as the prevalence of ILD in the setting of scleroderma. So cutaneous involvement is really the hallmark of this condition, and virtually all patients with systemic sclerosis will have Raynaud phenomenon, which is depicted here on the slide in the left picture. So these are color changes that happen in the distal extremities when a patient is exposed to stress or cold temperatures. Another hallmark is something called sclerodactyly, and this is the middle picture here. And this is when a patient has cutaneous sclerosis of the fingers of their hands. And this is a very severe case of it, where it's so tight that it actually causes contractures of the hands. So again, both Raynaud phenomenon and sclerodactyly are present in almost all patients with systemic sclerosis. And then on the right side here, you see an example of calcinosis. And this can also happen in patients with systemic sclerosis, but it's typically a later manifestation. So we typically classify patients based on their extent of skin involvement. So we classify patients either to having limited cutaneous disease or diffuse cutaneous disease. So if a patient has involvement of the skin from the elbows down, the knees down, and the neck up, they're considered to have limited cutaneous disease. If a patient has any involvement of their chest, their abdomen, their upper arms, or their thighs, we classify them as having diffuse cutaneous disease. And the reason why we make this distinction is because the evolution of the disease can vary based on the extent of skin involvement. So typically a patient with diffuse disease has a more rapid progression of their organ involvement, whereas a patient with limited disease typically has a slower progression of organ involvement over time. But both of these subtypes can get internal organ involvement, and I'd like to now go through some of those different organs that can be affected. So here we have the GI tract, and both the upper and the lower can be affected. And so when the upper GI tract is involved, patients can have acid reflux. They can have something called GAVE, which is when there's bleeding in the stomach. They can have Barrett's esophagus as well as gastroparesis. When the lower GI tract is affected, they can have dysmotility, small intestine bacterial overgrowth, as well as episodic pseudoobstruction. Now moving on to the lungs, there can be pulmonary involvement, so interstitial lung disease, which we'll talk a lot about here, as well as pulmonary hypertension. In addition, both subtypes can have musculoskeletal involvement, so the joint contractures, tendon friction rubs, as well as myositis. And then cardiac involvement can also occur, and this typically occurs in patients with the diffuse cutaneous disease, and this can manifest with pericarditis, a cardiomyopathy, as well as diastolic dysfunction and arrhythmias. And lastly, the kidneys can be affected in these patients. And again, this typically happens in patients with diffuse cutaneous disease where they can have renal crisis or renal insufficiency. So in terms of the prevalence of different organs being involved in systemic sclerosis, again, it varies somewhat based on which studies you look at, but you can see here from this slide that skin involvement, musculoskeletal involvement, and GI involvement is present in almost all patients with systemic sclerosis. And then after that, the lungs are involved in about 65% of the cases. And then beyond that, you can see lower percentages for the heart and the kidneys. And this slide here is talking about autoantibodies. And as I mentioned, we use autoantibodies to help us determine the underlying cause of a CTD-ILD, but then we can also use them to help determine the prognosis for the patient with the condition. So for example, there are some autoantibodies such as the SCL70 antibody, THTO, U3-RNP, as well as U1112-RNP that are associated with more progressive ILD phenotype. So in a patient that would have these autoantibodies, we may monitor them more closely and we may be more aggressive about upfront treatment in these patients. In contrast, something like the centromere antibody is usually present in patients who do not have interstitial lung disease, or if they have it, it's very mild. But what these patients do have a risk for, though, is pulmonary hypertension. And lastly, the RNA polymerase III antibody is associated with renal crisis. And the disease burden of ILD is actually quite significant. So systemic sclerosis has the highest case-specific mortality of any connective tissue disease, with an overall 10-year survival of about 63%. And among the causes of SSc-related death, ILD is the #1 cause of death, followed by pulmonary hypertension. If a patient comes in and we're suspecting systemic sclerosis, early on, the disease may not always be apparent, but we look for some early signs and symptoms which can be clues that the patient may develop systemic sclerosis in the near future. So one of them is fatigue, and fatigue can be a very nonspecific complaint, but in a patient who has a connective tissue disease, the fatigue can be disabling. So oftentimes patients after getting a full night of sleep will wake up still feeling tired, or they'll be at their job during the day and by the middle of the afternoon, they have to just stop and sleep. They feel so tired. So it's really a unique type of fatigue, a disabling fatigue. As I mentioned before, Raynaud phenomenon occurs in most of these patients, and this is usually one of the first symptoms, and this will happen sort of out of the blue in a patient. And they may notice it happens just in one finger at a time or in both hands. And then the puffy hands is what's demonstrated in the picture here. And what's important to notice is that unlike a condition such as rheumatoid arthritis or lupus, where you get swelling in specific joints of the hands, you can see here in this picture that there's basically swelling of the entire digit and of the entire hand. And this is very characteristic of the early phases of fibrosis in the skin in patients with systemic sclerosis. So a patient may tell you, they can't get their rings on and off, and their hands just look a lot different to them. And then finally, the ANA antibody. So this is not a very specific test, but virtually all patients with systemic sclerosis will have a positive ANA antibody. So if you see this constellation of symptoms, it's very concerning that the patient's going to develop systemic sclerosis. And I think this is a really critical point to understand, is that there's an evolution of these signs and symptoms. So if we look at the top curve there, this is a patient with diffuse cutaneous disease. And on the y-axis, you can see their skin thickness, so how much skin involvement they have. And then the x-axis is time, and it's looking over the course of 5 years. And what you can see is that the skin really peaks within the first couple of years and then gradually starts to soften over time. Whereas a patient with limited disease, which is represented by this orange line here, they may have a peak early on, but pretty much throughout the disease course, they're going to have a stable extent of skin fibrosis. But what's important to note is that in both of these subtypes, the interstitial lung disease typically occurs within the first couple of years of the diagnosis. And so I think in both of these subtypes, it's very important to screen for interstitial lung disease early in the course of the disease, because you don't want to miss this diagnosis. So now we're going to move on to a case. And in this case, this was a 55-year-old man who came to our clinic, and he presented with dyspnea and cough. And he had a cough that was dry, and it progressed over the course of 2 to 3 years. And along that same time, he had progressive dyspnea. He didn't have a significant past medical history, social history, or family history. And when we see progressive dyspnea over the course of 2 to 3 years, this is very typical for a presentation of a patient with early interstitial lung disease. On his review of systems, he reported mild stiffness and swelling of his digits. He also reported discoloration of his digits with cold weather, as well as dry mouth and eyes, but no difficulty swallowing. And again, a lot of these symptoms, again, the swelling of his hands, the Raynaud phenomenon, even the dry eyes and dry mouth in a man this age is very concerning for the development of an underlying connective tissue disease, such as systemic sclerosis. And on his physical exam, he had a little bit of tachycardia. Otherwise, his vital signs were within normal limits. On his skin, he was noted to have telangiectasias on his nose and upper chest. He also had some periungual erythema with infarcts and puffy fingers. And on his chest exam, on auscultation, he had bibasilar rales with no other abnormalities. And again, in a patient with ILD, if we hear these bibasilar rales, this is consistent with ILD. And if we see these skin findings here and these joint findings, this can be suggestive of an underlying CTD, such as systemic sclerosis. On his laboratory studies, he had a normal CBC, a normal complete metabolic panel, but he did have a positive ANA antibody of 1 to 640. And this titer is indicative of a moderately high autoantibody titer of ANA. And again, this is more suggestive that there's an underlying autoimmune disease. He also had a positive SCL70 antibody. And as we mentioned, this is a scleroderma-specific autoantibody that's associated with more progressive interstitial lung disease.
And I'll pick up here. And let's look at how we potentially can identify interstitial lung disease earlier in our systemic sclerosis patients. Well, it's really challenging because the symptoms are nonspecific. Fatigue, dyspnea on exertion, cough. Well, we see that in a lot of common diseases. In fact, we have the same problem in idiopathic pulmonary fibrosis where these symptoms can be confused with COPD or asthma. But in this particular population of patients, we really want you to add interstitial lung disease as a possibility. Many of these patients are asymptomatic, and there is a window where patients are asymptomatic before they come to clinical attention with symptoms. So we want to be cognizant of that as well. The first and foremost, I want to highlight what Dr. Volkman said. We need to do a very good history and physical exam on these patients. That is paramount because that's what's going to drive our further evaluation. We want to assess their symptomatology, assess them for any comorbidities that may be exacerbating their shortness of breath, cough, or symptoms. And we'll be talking about more of those in a little bit. But when those symptoms are apparent, or when there is suspicion of interstitial lung disease in our systemic sclerosis patients, we want to do a high-resolution CT scan in these patients. Why high-res CT? Well, frankly, we need that fine detail to figure out the architecture so that our radiology colleagues can help us with the pattern of fibrosis or inflammation on the CT scan and help us categorize exactly what that injury pattern is. The other thing that high-res CT scans provide is different positional pictures. One is we flip people over prone. The reason we do that is because fluid and heart failure can sometimes cause interlobular septal thickening and mimic fibrotic disease. We want to be able to capture inspiratory and expiratory imaging because on expiration, we'll capture air trapping, and we may see air trapping in small airways with connective tissue disease. We may see it in aspiration as well too. Pulmonary function testing helps us categorize restrictive or obstructive physiology. The 6-minute walk test gives us a concept of endurance, of the cardiopulmonary system, but it also gives us an idea of saturation nadir. What is their oxygenation with exertion? So this is our window into what's going on in their activities of daily living with this submaximal test. the important thing that I want you to remember is that in these patients with Raynaud's, you may not get an accurate saturation using a finger pulse oximeter. So think about investing in a head pulse oximeter so you can get a more accurate oxygenation and not a falsely low reading due to Raynaud's. And we want to think about capturing serologies as that may guide us prognostically. So again, chest x-ray has really been inadequate for mild or early diseases and really doesn't give us that architectural detail that we need to understand the pattern of injury. The most common pattern of injury with systemic sclerosis that we're going to see is fibrosing NSIP or an NSIP type of pattern. And we'll be looking at some images in a little bit. We want to think about checking an echocardiogram in our patients with shortness of breath as well, because we're looking to it as a screen for pulmonary hypertension. It has a risk of over or underestimating, but it's going to give us a pretty good first look at cardiac function and an estimate based on our tricuspid regurgitation of what those pressures may be in the pulmonary arteries. Again, an estimate at risk of over or underestimating those pressures. And we want to get baseline pulmonary function testing as well. We may see normal lung volumes and just a hint of reduction in diffusion capacity, and that may be our first clue to interstitial disease or pulmonary hypertension in these patients. So like many other connective diseases, we can see other organs present in a certain heterogeneity in different patients. So it makes it really difficult to predict who's going to potentially get what, except we have the help of our serologies in making us more cognizant to follow those patients with a certain serology positivity more closely. So again, patients with diffuse systemic sclerosis or scleroderma SCL70 antibodies may be at higher risk for interstitial lung disease, but remember that limited disease patients are still at risk as well. So let's look at survival and how that partitions out. Our limited patients are at the top at the darker line, and then the light blue line is the extensive disease. So you can see how that impacts survival. If we divide that up in severity based on forced vital capacity, essentially the worse your lung function is, the worse your survival is. So what do we do clinically? And our best expert opinion is laid out essentially in this algorithm. We want to do a good, again, it's all foundational on the history and physical with clinical examination. And I actually do use the nail fold Kaploroscopy. I love that. It's a very much a poor man's look at the blood vessels. And all you're doing, and you can do a Google image of this and see what normal and what abnormal is, but you're essentially putting a blob of KY jelly on the nail bed at the edge of the nail bed, so you can see the blood vessels just under the skin at the edge of the nail bed, and taking an otoscope and just keep turning the dial until you get a clearer image, and you're looking for normal, a nice nail fold capillary loops. Now, where this helps you is in patients with Raynaud's. If they have a disorganized vascular system with ectasia and disorganized loops, then that may suggest more of a systemic connective tissue disease and guide you to looking at patients with a complaint of Raynaud's very closely. We want to get PFTs, diffusing capacity, and consider a high-res CT scan. For those patients with no interstitial lung disease, think about looking at them again or assessing their physiology of pulmonary function testing, possibly a 6-minute walk at about yearly intervals. Or if they had developed symptoms or other signs that suggest they could have autoimmune interstitial lung disease, we're going to want to look earlier. For patients that have interstitial lung disease identified, generally we'll assess them in clinic about quarterly to every 3 to 6 months, depending on their disease progression course, or whether or not they have a slower disease with limited disease versus diffuse. If they have symptoms that change or accelerate, we're going to want to look at those things closer and earlier. Now, I want to highlight two comorbidities that are especially important. The first one, especially because a lot of times for us in interstitial lung disease clinic, when we see a patient that comes with a diagnosis of a fibrotic interstitial lung disease, such as like a fibrosing NSIP pattern, then we want to see what other clues are there. And we're trying to rule out autoimmune disease, drug toxicity, and environmental exposures that may be contributing to that injury pattern. Well, the esophagus is a big one, and probably just really in its infancy in our understanding the different injury patterns that can occur. And it's a very important one in systemic sclerosis. The GI tract involvement has a prevalence usually in about the 60% range or so, but depending on the study, between 54% and 90% of patients with systemic sclerosis. And the most frequent complication involves the esophagus with reflux and dysmotility. So reflux can occur in both diffuse and limited systemic sclerosis, and results suggest microaspiration spilling into the lung and contributing to potentially to lung damage. And we think that at least trying to keep things in the stomach and out of the lung may help impact treatment and potentially disease progression. So we want to focus on anything that could be reversible as part of this disease, and that's any modulating diets, therapies that we can do. But this is a very tough problem with not a lot of clean fixes or treatments. I want to highlight obstructive sleep apnea as well too, because it's been reported commonly in up to 68% of patients with interstitial lung disease and about 88% or so patients with IPF. But where obstructive sleep apnea comes into play is it can aggravate reflux. And we know that treating sleep apnea can lessen nocturnal reflux at night, which is such a significant problem in patients with systemic sclerosis with reflux. And that's because sleep apnea is just a floppy airway. When it partially closes or completely closes, intermittently for seconds at a time, there are very wide swings in pleural pressure. And when that occurs, the positive pressure from the abdomen and the negative negative pressures from the upper airway occlusion, where the patient's still trying to breathe against a closed glottis, can result in juices being refluxed back up and in the supine position very easily spill into the lung. So let's look at some risk factors for progression. Well, some of them we've already noted, but we're going to re-emphasize this. Male sex, African-American race, and advancing age, diffuse cutaneous disease of shorter duration, worse physiology, more fibrosis on a CT, and the anti-SCL-70 antibody. In clinic, the main biomarker that we can measure is CRP, and the higher the levels, the more concern. So slower markers of disease progression are, for the most part, a lot the opposite of that. Limited skin disease with the lower skin scores, longer disease progression where they've had longer periods of stability clinically in their pulmonary function testing, and also a milder amount of fibrosis on the CT. So that seems all a little bit master of the obvious, but it pans out to be true. Serologic profiles, including centromere antibody and RNA polymerase 3, are also factors associated with slow disease progression. So in summary, interstitial lung disease is a significant component to worsening the quality of life, function, and survival in patients with systemic sclerosis. So we really want to be cognizant of this, make the diagnosis early, and look for those things like the comorbidities of reflux and sleep apnea, where we can actually impact those that disease progression beyond the standard treatments that we're going to talk about in a few moments. Symptoms are nonspecific, so keep the concept of interstitial lung disease on your radar in patients with connective tissue disease. And early detection may help us get them on better therapies and treat their comorbidities. So we're going to pick back up with the case that Dr. Volkman started presenting. And I'm going to continue with physiology and CT scan pictures. So these are the patient's pulmonary function testing. And as we look at those, let's start by highlighting the spirometry and the lung volumes. So the spirometry really represents forced maneuvers and has a strength component in that too, with mildly reduced numbers that are symmetric in the forced vital capacity and FEV1. And if we look at the slower lung volumes and the total lung capacity, we see that there's a mild restrictive defect there. Looking at the diffusion capacity, which measures how well oxygen essentially moves across the membrane, we see more of a moderate reduction. So suspicion for interstitial lung disease plus or minus pulmonary hypertension. So here are some cuts of our CT scan. And if we look at the far left, the upper lobes actually look pretty good. As we go down, where just below the corona, in the middle image, we start to see more of a reticular pattern around the edges. And if you look at the very subpleural zone, especially in the right mid-lung zone anteriorly, we see a little bit of we call pleural sparing. There's just a little bit of a darker space around that. And sometimes that can be clues for NSIP for us as pulmonologists. On the far right, we see the basis of the lungs with much more involvement, reticulation, maybe ground glass associated with that reticulation as well. We see some a little bit of rugae in the esophagus, and maybe a hiatal hernia there. And the esophagus may be a little bit dilated on our central picture, where we'd usually see the esophagus as somewhat of a pinhole. And we've got that highlighted here and pointing that out with more ground glass. Dilated airways of traction bronchiectasis pulled open by the fibrosis that's adjacent to it as well. So in summary, this is a 55-year-old with connective tissue disease features of systemic sclerosis, mild restrictive defect, and moderately decreased diffusing capacity. The high-risk CT with NSIP and connective tissue disease features. So we're looking at the diagnosis of systemic sclerosis, ILD, as we're putting the whole picture together. I'm going to pass the baton over to Dr. Fernando Martinez, who's very well known in the pulmonary community. He's Chief of Division of Pulmonary and Critical Care Medicine at Weill Cornell Medical Center in New York. Thank you, Dr. Martinez.
Thanks, Lisa, I appreciate it. So I'm going to review some of the thoughts regarding therapy. I'm old enough, older than you two, to have been involved in a lot of these studies dating way back. And so I can tell you that it's actually really heartening to see the advance in therapeutic options. This is very different now than it was 20 years ago. And so there are a series of concepts that both of the prior speakers have highlighted for you. And a lot of that reflects the issue of diagnosis, the patterns of ILD, and there's been a consistent theme in terms of the importance of longitudinal following of a patient. to be able to define whether there is active disease, whether there's progression, and it has an impact therapeutically in terms of what you decide to do. So there have been a series of recommendations over time regarding the frequency of follow-up. I'm not going to take you through this entire slide and read every row. You can do that at your own time if you're bored and want to fall asleep. And so there are some consistent themes, however, and that is, if you look at the high-resolution CT column, you don't see high-resolution CTs every 3 months. We don't normally see that rapid a change in imaging, and so generally, the thinking pattern has been 6 to 12 months for longitudinal evaluation by that particular imaging technique. Pulmonary function tests are different, and that includes the spirometry and DLCO that Volkman talked about, the 6-minute walk that Lisa referred to, and both of those are relatively easy, they're relatively cheap, they're low risk. In the COVID era, it's a little different story, but at least pre-COVID, they were relatively benign tests to do. And so the recommendation has been to use more frequent physiological follow-up because it does provide prognostic implication. It's easy to do. And so you can see that there's a lot of consistency in terms of early on every 3 to 4 months, eventually every 6 to 12 months. But we do a lot more physiological follow-up because of the practicality and the advantages that that type of data provides. And so the thinking pattern regarding what you would consider from a therapeutic implication, Dr. Volkman, I hope I'm not misspeaking. My sense has been that there has been no God coming down and say, you must treat at this time point in disease. This is a complex series of discussions that take place at multidisciplinary discussions. We developed the first MBD a decade ago, and rheumatologists were not included. So now we clearly have brought in the rheumatology crowd because this is too complex a disease without your brains to be involved in this decision-making. And so the general approach has been really practical. I mean, if you look at this recommendation, the author is sitting there looking at me. And so the thinking pattern has been that if a patient has no symptoms and has normal physiology, what you do is you're going to follow that individual over time. That just makes sense, unless there is some dramatically at-risk component that you would see that would alter that thinking pattern. Generally, the consideration for us has been when we have suspicion that there is disease and that it's active disease. So you can imagine a person who's got symptoms that you are attributing to this particular manifestation of the scleroderma. Okay, that's something that you're going to have to consider treating. If that person has impaired physiology, Lisa has already shown you that impaired physiology is associated with badness in this disease. So that's got to trigger in your mind, okay, am I going to want to treat that patient at this time? And those are the discussions that we frequently have at our MDDs with our rheumatology colleagues as we review these patients. And if you're following a patient, particularly physiologically at relatively short time points, and you start demonstrating that there are deteriorations in lung function, increasing symptoms, certainly worsening imaging studies, that really has to trigger in your mind a thinking pattern that there is progressive disease here and I'm going to have to intervene. Fortunately, you got plenty of things now that you can consider for the interventional component. This wasn't the case a long time ago, but it is now. So this is one of the first studies that was performed in this field. So Don Tashkin at your institution there, Dr. Volpin. So this was one of the first studies that we were involved in that looked at the concept that since there is such a strong inflammatory component in this disease, there is a fibroproliferative component as well, but there's a strong inflammatory component that tested cyclophosphamide. And it was a study that had really robust findings demonstrating that in an appropriate patient population, that if you gave cyclophosphamide versus a placebo, you tended to see more improvement. The people that are up in the y-axis are people who are improving. People below are people who are deteriorating, and the frequencies are on the x-axis. And cyclophosphamide is on the left, placebo is on the right. And you see that with cyclophosphamide treatment, more patients improved, less patients worsened. It was the reverse in placebo. So this was a demonstration that in a graphical format, you had clear evidence of improvement that was seen with this particular intervention. And so if you look at the longitudinal time point of forced vital capacity, that's the description of the spirometric parameter that Lisa Lancaster gave you. It is the easiest, most reproducible of all the lung function parameters for us, which is why it's one that's been used as a primary endpoint in studies targeting the lung. You see that there was improvement with cyclophosphamide, stability, if not a little bit of a poopiness with placebo. And this was a 1-year study, and then there was a 2-year extension that was published subsequently, and you see that there was continued improvement. So this was a major finding for us because it was clearly a demonstration that in this particular disorder, a rare disorder with a bad lung involvement, you could favorably intervene. So we were like, woohoo, this is really good. So then the next question was, well, Cytoxan is not the easiest thing to administer, right, Volkman? I mean, that's not the simplest thing to administer. And so the next thought was, why don't we consider an alternate agent that can be administered orally? And so we went into scleroderma lung study 2, where we said cyclophosphamide worked. What about mycophenolate? Could we contrast those two agents? The same investigator at your institution there was the driving force behind this study. On the left-hand side, you see that cyclophosphamide and mycophenolate, they both did pretty well with regards to the forced vital capacity. On the right-hand side, you get a hint that, mycophenolate, cyclophosphamide, there are the comparisons between the two. It's not a bad-looking comparison for that particular agent. And in fact, you also saw improvement in breathlessness. So this was an extension of those findings and suggested that, yes, cyclophosphamide works. Mycophenolate, which is easier, likely lower risk to administer, worked just as well. And so you saw an evolution in the field towards a more routine use of mycophenolate in this disorder. And Dr. Volkman, we're going to come back to that patient again in a second, because I want to see your interpretation of those data. There have been our rheumatology colleagues who are much smarter immunologists than we are, Lisa, in pulmonary, that's just a fact of life, that have attempted a series of innovative therapeutic approaches. Rituximab targets CD20. It is a B-cell driven therapy, and it profoundly affects B cells. And there has been preliminary study suggesting that it does have an effect in scleroderma-associated ILD. There's actually an ongoing study comparing it to cyclophosphamide. So I'm very interested in seeing those results. And one of the questions that I'm going to ask you later, Volkman, is going to be where you put rituximab in your therapeutic algorithm, because I have this discussion with my rheumatologists all the time. Because it's a very potent agent that clearly does seem to have some effect in this disorder. If you really want to get aggressive, there's stem cell transplantation. So there have actually been randomized trials of cyclophosphamide versus transplantation. And you can see the results. I mean, though you don't need an advanced biostatistical degree to look at that and tell me that those curves seem to be separating with regards to survival. So this is clearly a potential option, but if you think cyclophosphamide is complicated, stem cell transplantation is really complicated. And so this is a therapeutic approach that really needs to be very carefully selected in conjunction with your rheumatology and hematology colleagues, because the patients have to be very carefully selected, and it really has to be done at centers that have a lot of experience in this arena. This is not a simple intervention to intervene or to introduce in a patient. So you can get a sense that a lot of the therapeutic thinking pattern up until now has been focused on this. It's an inflammatory pattern. Lancaster told you she checks the CRP in her clinic, for God's sake. So we're monitoring the inflammatory focus. One of the things that I think has changed in this field has been the concept that there is a parallel in some patients, more of a fibroproliferative type of disease. That, you see it in the skin. Volkman, you were describing all the pictures of all the changes in the skin. Those type of changes where you have an activation of fibroblasts and extracellular matrix deposition certainly is something that we see in the lungs. And so with the availability with anti-proliferative agents that actually work and can be given with pretty good tolerance, it was a logical extension that you would consider that potential approach in patients with scleroderma-associated ILD. And sort of the largest of these studies, it's really the largest study performed in scleroderma ILD, was a study looking at nintedanib, an anti-fibroproliferative agent. And it was a large study. I mean, this is a large study for ILD in general. It's for scleroderma, it's a really large study. And it was a randomized control trial, well done, nintedanib, standard dose, placebo, and patients were treated for a year. That was the primary endpoint, and then there was an extension afterwards for patients that were enrolled later or earlier on. And it was assessing forced vital capacity. So this was using the paradigm, Lisa, that we've seen in IPF, a different ILD. But FVC does illustrate the changes in lung structure, easy to measure. So the primary endpoint was feasibly and appropriately an FVC. And then there were a series of additional endpoints that were predefined, including a measure of scleroderma skin findings. So that's going to be an interesting topic of discussion. There was a measure of quality of life as well. The patient population, given what Volkman described for you earlier in terms of the characteristics of these patients, it's interesting to see the inclusion criteria for this particular study. And they included patients that had a clear diagnosis of scleroderma, that it had a duration of less than 7 years. We'll come back to that potentially in the discussion period. There was clearly, Lisa, evidence of interstitial involvement on a CT scan, and there were appropriately physiological parameters. And interestingly, patients were allowed to be on a background anti-inflammatory approach as long as it had been stable at the time they came into the study. And so when you see, when Lisa, you and Elizabeth were talking about the presence of ILD with diffuse and limited, there you go, you can see it in both, and that's the population that was enrolled in this study. The majority of individuals had the SEL70 that was positive, and about half were taking mycophenolate. We will come back to this half taking mycophenolate in a second. And as you would imagine, given the inclusion criteria which required interstitial disease, these patients had significant interstitial changes on their high resolution CT. That's the first row. They had restriction and they had decreased DLCO. So again, it is appropriate then to consider that this is the type of patient population that develops progressive ILD, and it's appropriate in the representation in this particular study. The component that was exciting for everyone is, hey, it worked. And so actually when you use an antifibrotic drug, not principally an anti-inflammatory type drug, but an antifibrotic agent targeting a series of tyrosine kinases, the primary endpoint was clearly impacted favorably with nintedanib. So there was a greater loss of lung function, worsening of disease physiologically over the course of time with placebo, which was decreased in half by the addition of an antifibrotic agent. And if you like seeing things sort of longitudinally over time, you again see a clear separation that's occurring in that first 3 or 4 months or so when patients are treated with this particular agent. So clearly it worked from a pulmonary standpoint. Interestingly, it had very little change in the skin findings. And there were really modest changes in quality of life, but this is not, SGRQ was not a quality of life instrument. It was developed for scleroderma. It wasn't even developed for ILD. It's a COPD. It's my other life. That's what it was developed in that component. And so one of the questions that we ask ourselves is, this clearly, the physiological component clearly was a win, no doubt about it. The skin findings, not so much so. So that's a question that I'm sure someone's going to ask. And I told you to keep in mind this issue of the mycophenolate, because remember, about half the patients were allowed to continue on their mycophenolate through the study. And if you look at the patients in a predefined analysis, at the patients who are on mycophenolate at baseline, the left-hand panel, versus those that were not taking mycophenolate, the right-hand panel, you saw that nintedanib worked in both groups. So the nintedanib loss of lung function was less than placebo in both of those groups, but you get a sense that the magnitude was different with regards to what you saw between those two groups. It's not the relative effect of nintedanib. My sense is mycophenolate works, and mycophenolate tends to attenuate some of that loss of FVC. That's why the placebo groups are different between those two arms, but the nintedanib effect is still there. So one of the questions that will come up is at what point you consider predominantly an anti-inflammatory versus an anti-fibrotic approach, and that's a question that will come up in a second. The sequence of adverse events are no different than what you would have anticipated. We've had a lot of experience with this particular agent in ILD and IPF. There are well-designed studies that led to its approval in IPF. So we know that the side effects of nintedanib are principally gastrointestinal in nature. And so the data that you saw in the scleroderma ILD study, in the Census study, were not surprising. There were GI side effects. It was nausea, vomiting, and diarrhea. That's the same thing we see with this agent. It wasn't qualitatively any different. It may have been quantitatively a little bit higher because you see a bit more GI symptomatology in this patient population than you see in an IPF population. But there was nothing new or dramatic that was different. So the evolution from a principally anti-inflammatory treatment to an antifibrotic therapy now showing both of those approaches work. So it's not surprising that the other antifibrotic that's been available to treat idiopathic pulmonary fibrosis, pirfenidone, has been studied, and it continues to be studied in this particular interstitial lung disease. So the first of these studies was Dinesh Khanna. This was while he was at Michigan, no longer at UCLA there at Volpin. So this was a study of pirfenidone over a relatively short time frame, but it was a controlled trial. It really was a study that was looking at tolerability of the drug. And so that's why this is not a census-like study in terms of its design. And what you saw was that there were treatment emergent adverse effects, that's that TEAE, and that it was very similar to what we had seen with pirfenidone and IPF, that they were sort of dose-related and there was a dose titration effect. It's the same as what we do in IPF. The adverse events were also similar to what we've seen previously. And so I think that we all had a sense that pirfenidone in this type of a study, this is not a large efficacy study, has a tolerability profile which is as expected. So you shouldn't be surprised that there's a randomized controlled trial testing efficacy in this patient population ongoing, and we're all involved in trying to recruit this trial. So it is a study where you look at pirfenidone versus its matched placebo in patients that are on standard therapy. And it is, it's as you'd imagine, it's sort of a typical study with regards to the duration and the endpoints. We're all awaiting this study with bated breath. It's not the only study that's ongoing. There are multiple studies that are ongoing in this field. We're waiting for the tislelizumab study, which is about to come out. It's already accepted and it's in press. But there are a whole series of approaches that vary in their approach with regards to a little bit more of an anti-inflammatory effect, multiple different pathways that are potentially more of an antifibrotic effect. And so this field is going to become, for you, Dr. Volpin, much more of a challenging field in a good way, because you're going to have multiple options in a given patient that you're going to have to be discussing in your MDDs for each of these patients. That's a very good thing, guys. For people like me who've been at this a long time, this is much better than what we used to do, because now we have a lot of options. Lisa brought up really elegantly the issue of the esophagus in this disorder. And it is particularly relevant to carefully assess symptomatology for this particular comorbid condition, because it may have primary impact in terms of driving fibroproliferation, as Lisa had pointed earlier. So assessing for symptoms, whether it's the reflux or dysphagia symptoms, aggressively modifying with lifestyle modification, with proton pump inhibitors, aggressively proton pump inhibitors, potentially pro-motility agents. All of those are components that I think are important to consider. Surgical intervention, I think there's a question mark there for a reason. I don't think any of us have any clear idea. And we've tested that already in IPF with sort of inconclusive findings. But the component of understanding the importance of assessing and aggressively managing esophageal symptoms is, in this case, particularly crucial. So I hope from all of the speakers you've gotten a sense that scleroderma is a tough nut to crack. It's a disorder that has a lot of protein manifestations. ILD is important because it's a killer in these patients. There is a really good sense now evolving of the approach to the evaluation, the approach to the monitoring of patients, and we have a much better sense of the components regarding treatment. And if you look at that box on the right-hand side, there are multiple things in that box regarding therapeutic approaches. So those are all really good components that are relevant to our patients. And that leads to the next question for us, which is, from a practical perspective, how do you apply that in an individual patient? That leads to this concept that you've seen woven throughout the presentation of how I treat. Okay, Volkman and Lancaster, you ready? Because let's pretend that we have a multidisciplinary discussion. We had this here yesterday. And how are we going to apply that to this individual? Lisa is the same exact patient that you and Elizabeth presented from the very beginning. It is exactly the same individual. So the left-hand side is the mild restriction with the decreased DLCO, and he's got evidence of fibrotic changes, some ground glass, and that subpleural sparing, which is very NSIP-oid. Dr. Volkman, he is symptomatic and has those components. What would you like to do?
Well, yeah, I think the first question here is, when do you start treatment? And I think in this patient, this would be the appropriate time to start treatment, right? Because he has symptoms, he has restrictive physiology on his PFTs, and he has fairly extensive ILD on his CT imaging. In addition, if you remember, he possessed the SCL-70 antibody, and he's a male, and those are two risk factors for having a more progressive phenotype. So I definitely think that we would start therapy in this patient. And in terms of which therapy to start, I think based on the wonderful summary that you did of the studies that have been conducted to date, I would probably start with mycophenolate in this patient because this might lead to an improvement in lung function, and potentially it's safer to use than, let's say, cyclophosphamide.
All right, so think about the thinking pattern that she's done here, because this is the same discussions we have at ILD. She's thought in her mind, what are the risk factors in this patient? What is the likelihood of progression in terms of intervention? Let me ask you one quick question. So he has telangiectasias that are over his chest. Does that count for diffuse disease or not?
No, so that's a good question. Telangiectasias can be present in patients with systemic sclerosis, both limited and diffuse disease. In fact, sometimes they're more prevalent in limited disease. The way we define diffuse versus limited really has to do with thickening of the skin.
All right, perfect.
Great question.
So, in fact, there you go. Mycophenolate was started, and he is now on this agent. He titrates up over the course of a month or so, and he is back in your clinic, Dr. Lancaster. I keep pronouncing you like the city in Pennsylvania that my son went to college in, not Lancaster, but Lancaster. And there are his repeat pulmonary function studies. This is about 3-4 months after being on full dose mycophenolate. Lisa, what do you want to do with that?
So we have signs and markers that he's progressing despite the mycophenolate. And the tough thing to know is for any of these medicines, what would they do in the absence of that medicine, on or off? But regardless, we're seeing the decline. So the next thought is, what can we add to slow down the disease progression of the interstitial lung disease, while also making sure that we manage comorbidities like reflux? We want to take the kerosene off the fire. Yeah. So in general, our next step would be to think about nintedanib.
All right, so let me ask you a practical question. This is about 3 or 4 months later. You've seen this physiological study. Would you get a CT at this point? Or do you think you have enough information to make that decision based on what you have in front of you?
I think I have enough information to make that decision in front of me. But if I was suspecting something else occurred out of character, or I suspected worsening reflux or aspiration playing a role, I think I'd want some imaging.
Okay, so let me tell you what happens.
You may want to also even consider getting an echocardiogram, because you can see his DLCO went down disproportionately to his FVC. So he could be also developing pulmonary hypertension that would require treatment too.
All right, perfect. I love it. So his echo is okay. That was done at this point, but he had much worse reflux. And so we intensified the reflux management, and he is now on high dose PPI and a pro-motility agent. And he wants to come back in a few months. He comes back in a few months. Those are now his PFTs now, and his CT, the equivalent locations about 6 months after the baseline. You two ladies, you're in the middle of your MDD. What would you like to consider at this point?
I think all the things that we've discussed so far are on the table, and that next step would be nintedanib. He's got in the far right picture, almost like an air fluid level there. So I'm worried I just would want to make sure that he is controlling reflux and doing all those abrogation maneuvers. And then looking in potentially for sleep apnea as well too, since that may aggravate reflux and reflux aspiration.
Volkman, what do you consider as your changing or adding for therapy in this kind of a patient?
I think sometimes we make that decision too based on what's going outside of the lungs in these patients, right? Because it's a systemic disease and the lungs are just one component of it. So if this was a patient who had diffuse skin disease that was also evolving despite treatment with mycophenolate, we may even consider doing something like rituximab, which would help both the skin disease and the lung disease. But if we're just looking at progression of lung disease, then I think Lisa's suggestion makes sense to add on nintedanib therapy, but you could also consider rituximab in that case as well.
Perfect. I love it. He actually started nintedanib. He's on it now. I can't tell you what's happened because he's only been on it for a couple of months. And I will turn it back to the boss. Lisa,
So we'll start with questions, and we have two that we have time for. So the first one is, what are the autoantibodies useful for monitoring disease or response to therapy? And Dr. Volkman, I'll throw this one out to you.
No, it's a really great high-level question. So typically we use these autoantibodies to help us with the diagnosis, as well as to inform us about the prognosis of the patient. We don't typically use them for monitoring disease progression. And this is because the titer, the level of the antibody, typically doesn't change over the course of the disease. So these are often just measured one time at the beginning. Now, this is different than other autoimmune diseases such as lupus, where we'll look at something like the double-stranded DNA antibody, and it does fluctuate and correlate with disease activity. But at this point in time, with the specific autoantibodies that we have, we don't typically use them to monitor disease progression or response to therapy. Hopefully in the future, we'll have biomarkers that will help us do that, but it's a great question.
Great. And so we'll go to our final question. What is the relationship between GERD and HRCT progression? And I'm going to turn to Dr. Martinez for that one, and maybe you can highlight even acute exacerbations in that discussion.
Yeah, I mean, it's a great question for which there's no good answer. It makes conceptual sense that reflux, particularly uncontrolled reflux, would be associated with progressive disease, given the biology that Lisa described. And there have been associations in other disorders, IPF, with reflux associated with disease progression and with an increased likelihood of acute exacerbations. And there actually is a fundoplication study in IPF that suggested benefit in that setting. And so I can't answer that concretely in your scleroderma patient, but I can't imagine that there's not a relationship and that it's not particularly relevant in this population to be really, really, really aggressive in the management of esophageal symptoms and disease.
So true. I think we're pretty much in our infancy in understanding the different injury patterns and how reflux can in general aggravate connective tissue diseases across the board. I really want to thank you all for attending today, joining us in the middle of a very busy day. A lot of you are dealing with COVID surges now. I'd like to thank Dr. Fernando Martinez and Dr. Elizabeth Volkman for their outstanding presentations, and again, making a very complex topic much cleaner and simpler and concrete for all of us. Thank you for your time. Thanks for joining us today, and we appreciate your attendance.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/RUB860. This activity is supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.